Good afternoon. It's really an honor and a privilege to return to Chicago. I echo Dr. Stephen Lewis's words this morning. I always feel that this is one of the finest meetings of the year, and I'd like to thank the Scientific Committee, the Organizing Committee, and AAOMS, and especially my good friend, Dr. Michael Block. I'd like to be able to review a bunch of different types of information this afternoon in a short amount of time. So bear with me as I try to explain how I truly believe, and I'm very passionate about technology. And I think technology is our friend, and we should embrace technology. And it's kind of basically a philosophy on how we place and how we restore implants, but also beyond that, how we communicate with our colleagues and how we can develop the communication skills utilizing this technology, which of course ends up benefiting our patients. And I'm going to talk about planning. I'm going to be talking about diagnosis, treatment planning, and a philosophy. It's a philosophy that I have and I carry through to all of my patients and all of my planning, and I hope to impart some of that information to you today. Ideally, if you want to be able to work with your prosthodontic restorative colleagues, you want to be able to have a plan in advance if you're going to use this technology. Radiopaque scanning appliances allow us to be able to see and interpret the position of the desired restoration against the underlying bone. And we can accomplish that with radiopaque scanning appliances utilizing barium sulfate and various different means. I prefer to use a fully opaque tooth, especially when I'm doing single or multiple teeth, and I use a percentage of barium sulfate in a complete edentulous situation like you can see here demonstrated in a maxillary and mandibular scanning appliance. Because even if you embrace technology and you send your patient for a CT scan, one of the things that you cannot appreciate, although you can clearly see the anatomical landmarks in this maxillary arch, you cannot appreciate the location of the tooth position. And therefore, we need to have a scanning appliance, ideally, that is utilized at the same time that the patient is scanned. Once that is accomplished, we can set forth new paradigms to be able to address some of the concepts that many of the other previous speakers have addressed. But this ability to be able to use the scanning appliance allows us to be able to then combine that with software applications so that we can use what I term selective transparency so that we can see through these images and be able to understand the location of the implants in relationship to the bone and to the envelope of the teeth that we're going to replace. And so we can understand the trajectory, we can understand crown-to-root ratio, but more importantly, we can communicate as colleagues as to what the end result should be before the scalpel ever touches the patient. And so when we can utilize the technology, and here we see an example of cross-sectional planning, we're using a cross-sectional image here to be able to show the bone as well as the scanning appliance. So this gives us a tremendous amount of information. However, if we just go ahead and place an implant and use an abutment projection, we can see that we may not be exactly in the best restorative position. We're outside the envelope of the teeth. And unfortunately, we see this far too often. Perhaps it would be better to be able to place an implant within a concept which I have described many years ago called the triangle of bone so that we can avoid off-axis placement and potential lateral forces, as Steve Lewis explained earlier, which are very detrimental to the restoration, whether we're doing a single tooth or a full mouth reconstruction. And so when we want to evaluate this area, especially in the cross-section, we want to be able to view the zone, which I've called the triangle of bone. And so here we can see the most volume that would surround the implant in this particular cross-sectional image. And so I suggest that we take some of the articles that Dr. Leopardi had mentioned earlier this morning and be able to talk about new paradigms, such as the ability to be able to now assess the true volume of bone surrounding these implants as they exist in relationship to the tools that we have to go through, for instance, a cross-section of the 3D model, which clearly identifies the cortical intermedullary bone, as well as being able to assess now the trajectory of the abutment versus where the tooth position should be. And when we take a look at measurement tools, we are no longer concerned with just measuring around the crest of the implant and being able to determine how much bone we want to achieve facial to that implant or lingual to that implant, we also want to be able to look at the entire length of the implant to be able to determine what kind of bone volume surrounds that from the crest all the way down to the apex. And therefore, we can certainly achieve some very accurate placement. And so if we take a look at this panoramic reconstruction, and you see a failing dentition here on the left-hand part of the screen, and we're going to plan to remove these implants, and we're going to place 4 implants into the posterior right mandible. But how do we accomplish that? Well, first of all, we'd like to be able to see the trajectory of the nerve, and can we accurately be able to place 3 out of the 4, because in this area we're going to end up having to graft because the bone volume isn't there. Now, are we going to be guessing, or are we going to start to utilize some of the technology that we have at the disposal today? Cone beam CT has brought down many of the barriers which have prevented us from using this technology widely. Today, having cone beam CT scan machines in the office is a very advantageous thing, especially for many of the oral surgery colleagues that are here in the audience today. It's a wonderful tool. It allows us to instantly be able to assess the cross-sectional, axial, and panoramic images, and then we can import it into other ancillary software applications to be able to assess the position of the nerve, as you can see here, versus the position of a realistic implant and an abutment projection. And we can also appreciate the concavity as it exists in that middle image on the lingual area of the mandible. Once we can put these cross-sectional images together, we can start to assess each site, and by assessing each site, we can start to be able to appreciate the anatomy. We can utilize a realistic type of an implant, whatever implant system that you may want to utilize in your practice. We can use simulated abutments, or perhaps it would be good to be able to combine this with the actual restorative components that we will utilize for our patient, so that we know in advance exactly what the plan is. We also want to know exactly what the cost is. So in this particular area, of course, we can see that there is no bone in this area surrounding this hopeless tooth, and it would be foolish to probably place an implant and graft at the same time. It probably would be better to graft first and place the implant later. And we can accomplish this planning utilizing this technology. Very simple and very easy. Now, when we want to take advantage of the design of the implant manufacturers, implant manufacturers design implants most of the time thinking that the bone is always going to be flat. Well, of course, we know that the bone is hardly ever perfect, and we have to either adjust the bone or deal with the condition of the bone as it is. So here we see an implant is placed at a crestal placement right at the crest of the bone, and if we have to evaluate the biomechanical properties or the specific properties of the surface treatment of this implant, perhaps when we start to place it in a supracrestal environment, utilizing some of the micro threads at the top of this implant design, seeing the correlation between the bone and the soft tissue and then the abutment, it starts to give us a concept that the implant manufacturers would like us to achieve. However, in most cases, we actually may not be placing the implant in either of those 2 locations. We may actually be placing this in a transitional placement, where we have a bone that's higher on the lingual and lower on the facial. And therefore, we have to appreciate the design features of the implant and whether or not this would be an ideal placement, or we have to make some decisions about grafting or some other treatment in that area. And so when we start to look at the position of this implant, and we start to think about the planning, as this is one of the most often types of treatments that we're going to be facing, if we look at this cross-sectional image, we can validate the fact that if we place the implant at the height of the lingual placement of the bone, on the facial, we will have either threads exposed or part of the implant exposed. Now, is that going to go along with the design features of this particular implant? It may or may not, and that's where we have to make some decisions. We can use realistic implants, we can use realistic abutments, and we can use three-dimensional images to be able to assess this site in ways that we can never do in any other manner. And so when we talk about minimally invasive procedures, I believe that minimally invasive flapless surgery can be certainly an effective treatment modality and has been demonstrated by many clinicians and some of them here at this meeting. However, I believe as a prosthodontist that when we take a look at the available existing bone anatomy and we also combine that with the available keratinized soft tissue, it often requires that we raise a flap and we evaluate that bone and we move the soft tissue or the bone or graft or do some other procedure to ensure long-term success. So when we want to look at 3D reconstructions and the tools that we have available today, here we have the existing bridge, and we can segment this out through masking procedures where we can separate the structures. We can then place the implants into this area. We can look at the trajectory of those implants, and we can look at those trajectories and examine them within the confines of the teeth that we're going to replace. And so that's one solution to trying to have advanced planning. However, we can go one step further, of course, by using that selective transparency tool and understand the placement of the inferior alveolar nerve and, of course, where the mental foramen exits from from the mandible. We can then go one step further using virtual teeth. With virtual teeth, we can go in and we can actually look at a virtual wax-up of the proposed occlusion. And this, to me, is a wonderful step forward that's going to eventually be the link between planning virtually and being able to deliver CAD/CAM structures directly from the CT image. And so we can evaluate implant-to-tooth, implant-to-implant relationships, not just from a periapical X-ray, but from a three-dimensional positioning of these implants into our virtual patient right now. Of course, this is a real patient, which we have segmented out both the teeth so we can examine these locations. Once we are satisfied that we have created a plan that satisfies the restorative and the surgical nature of the presentation, we're going to then allow this data to be sent over for the fabrication of a surgical guide or a surgical template. And that surgical template is going to be representative of the positioning of those implants. And so here we can utilize some animation to be able to show you that we can remove the bone, we can evaluate the position of the template. If we wanted to fixate this template, we could create the positioning of the fixation screws, as I will demonstrate. We can look in the intaglio surface. We can see the implant-to-implant relationships, that they're all parallel, and we can examine this in a means that is totally virtual before we ever touch the scalpel to the patient. And then, of course, we have had, over the last 10 years or so, the influx of the new technology known as stereolithography, which creates both models and the templates to help us then deliver the concept of the plan to the patient at the time of surgery. We can go in here and we can use these stereolithographic models to take the analogs that represent the implants, place them within the stereolithographic model, or create it from a different approach, and be able to then, of course, go to the laboratory, look at the virtual wax-up, and then an actual wax-up to be able to create a temporary situation utilizing abutments that will support our transitional restoration. However, which abutment is proper for that particular area? Are we going to use a conventional abutment that may come with the implant itself? Depending upon the design of or the actual implant that we're going to use, we may in fact want to use one of these type of abutments and use different tissue cuff heights that will allow us to be able to understand the restorative components, again, before we ever touch the scalpel to the patient. So it becomes extremely important that we can link the surgical plan with the restorative needs. So here you see this is an angulated abutment which is pre-contoured. It has prefabricated margins, which is going to mean that if the implant is rotated in a poor position, then this abutment should really not be used. So here, if we have this advanced planning, we can place our implants, we can place our abutments in the stereolithographic model, and then we can go to the patient. All of the planning has been done in advance. There are no decisions to be made at this point, perhaps except how to extract the teeth and how to deal with the soft tissue. So the preoperative condition, we extract the teeth, we place, in this case, a tooth-borne template, and we're going to go and place our implants exactly according to plan. And in fact, we can get these implants to be perfectly parallel, helping us to create a temporary restoration with the proper type of an emergence profile and allow this to then heal. So we can go from this condition to this condition, knowing that we're going to come back after this graft has matured and we'll be able to place the fourth implant. Again, all according to plan. And we're also going to be able to do this with the knowledge that we're going to place the implant at the height of the lingual crest of bone, leaving some of the area on the facial, which we will then add some bone grafting material. So when we have the ability to use realistic implants and then realistic abutments, we have the ability to be able to go far beyond traditional planning. Because here you can see the angulated abutment that we're using, and we can rotate it and we can spin it. We can see how it it approximates the implants next to it. So this goes, to both what Dr. Lewis and Dr. Leopardi were talking about earlier today in terms of implant-to-implant relationships. Well, we can assess all of this in advance so that we know if we're going to place 1 implant or 2 implants or 4 implants, understanding where the contact areas need to go, understanding where the restoration needs to go, and we can easily communicate this with all of the members of our team. Now, realistic implants and abutments are part of the equation. We have the ability to choose from any one of the implant companies that are available today utilizing the sophisticated software that is out there. And by being able to use realistic implants and then realistic abutments, it is the true link between the planning, the surgery, and the restorative capabilities that we have today based upon this technology. And so having that concept, we can then be able to link not just one of the images, but we need to be able to link all of the images. In this particular case, we're looking at the panoramic view, the cross-sectional view, the axial view, the 3D view. Those are going to come together. Not just one. We need all of them to create the plan. And that plan then, of course, creates the template. And so we have to be able to embrace technology by understanding all of these are important to be able to assimilate before we ever touch the scalpel to our patient. And of course, you've heard me probably many times before make the statement that it is not the scan that is important, it's the plan. And so many people think that this is all guided completely by the computer, and that is the furthest. The computer is only part of the equation. So who creates the plan? Is it the computer? It's absolutely not. The plan is created by you, the person that is controlling what the computer does. And so we have to be able to evaluate the anatomy in order to be able to do that. And so if we take an example of another immediate load type of situation where we would go in here, extract these hopeless teeth, well, we're not going to just go in there haphazardly. We're going to go in there, evaluate the three-dimensional assessment of the bone, and we're going to utilize some of the advanced transparency and modeling features of the software to be able to both assist in the planning of the implants, but also evaluating the anatomy, both the tooth, the root anatomy, and the bone anatomy. We can go in there and accurately assess where the nerves are going to go, and we can actually make these implants perfectly parallel, if we desire to have them parallel. Sometimes they are not desired to be parallel. But if we have that capability and we combine it with the virtual teeth to now put the occlusion together with or without a radiopaque scanning appliance, that takes us into the next level of sophistication. And so having these capabilities is really remarkable, and it has been a long journey for the last 20 years getting to the point where we are today. And so when we extract the teeth, we're going to use a bone-borne surgical template. The bone-borne surgical template will sit on the bone. It can be fixated. It may not be fixated. And so we have 3 different types of templates that we can talk about: bone-borne, soft tissue-borne, and tooth-borne templates. These are all part of the armamentarium that will then help us place these implants into the proper position based on exactly the implant virtual design that we have chosen in our virtual plan. And so here we have 5 implants that are placed parallel, good anterior-posterior spread, and that's what we want to be able to achieve. And so when we take a look at the post-operative confirmation using cone beam CT with the low radiation, we can use this tool to be able to confirm some of our surgical interventions. And so one of the statements that I'd like to make is that when you install a cone beam CT scan machine in your office, it's not the end of the process. It's not the end of the deal. It's just the beginning of a whole new and ever-expanding educational experience for you, your patients, and all of the members of your team. Now, many years ago, I came up with the concept of the restorative dilemma. The restorative dilemma is what you basically have seen with Dr. Lewis and Leopardi. And basically, it's the description of the morphology of the teeth that you can see here. That tooth morphology is not round. The teeth that we replace are not round. So how can we evaluate this better? Well, we can start to look at implant-to-tooth relationships and implant-to-lamina dura relationships and implant-to-root relationships that we cannot be able to assess with any other treatment imaging modalities. So this is a very exciting time for all of us, I believe. And when we look at that restorative dilemma, we have to be able to understand that we can use virtual implants. We can then use this as a wonderful teaching tool to assess anatomy. For instance, if we had a 3.8 millimeter diameter implant, is that the proper implant for a central incisor? Well, it may or may not be. If we take a look at that gap distance, it may be too great. If we want to then go in and look at a 4.6 millimeter diameter implant, that may be more appropriate. or a 5.8, it may be too large for that site. And so we have to be able to assess this to be able to place the implant, make sure that we have good emergence profile, and that we're placing an implant that will best support the dentition in that area. And so we have to make these decisions based on the science of what we have in front of us today. So the restorative dilemma, based upon this tooth morphology, we can readily determine, we can look at the implants and we can place them into simulated extraction sockets, and we can look at a case like this where we extract the tooth, and we can, in fact, be able to look at three different types of diameter. Here's a 5/8, a 4/6, and a 3/8, a canine, a lateral, and a central incisor. So I truly believe that there is a danger when we are bound by two-dimensional concepts when we live clearly in a three-dimensional world. And so when we take a look at the next evolution, it would be for CAD-CAM restorative components. When we look at virtual CAD-CAM abutments, we can start to see how we can link these together to be able to assess the virtual position of the implant and the abutment design, so that we can, in fact, be able to create beautiful abutments that have the right kind of emergence profile that we would like to try to achieve. And we can use some of the new tools that will be coming out to be able to communicate better with all of our colleagues, such as virtual viewers that allow us to be able to see these abutments and these CAD-CAM designs before we ever let them be created in or fabricated in metal or zirconia. And so when we take a look at this enhanced communication and the tools that we have available to us today and that are coming in the near future, I think it's going to be remarkable. Because when we look at CAD-CAM abutments, when we look at the soft tissue, when we look at what we can achieve utilizing either metal or zirconia, we have the ability to be able to help our patients achieve levels of aesthetics and success that we haven't been able to achieve before. But what if we wanted to go directly from the CT scan directly to an abutment? Is that possible? And certainly, I have shown this for the last several years. As long as we can control the anti-rotational feature of the implant itself, we can go in and we can create a realistic abutment virtually. We can then send this out to be milled, and we can have a patient-specific, site-specific abutment based upon a virtual positioning without ever having to take an impression. That's the next level that's coming, and it will be here, hopefully, in my lifetime. I'm looking forward to it. So we can go from CT scan to abutment. We have done it, and we hopefully will continue to try to do it. So as an example, here's an implant. Here is an abutment that's a stock abutment. Here's another stock abutment that's out of the plane of the occlusal part of the tooth, or the envelope of the tooth. And we can use a stock abutment, and we can go from CT scan to stock abutment, as I've shown you before, or we can go from CT scan to a custom abutment, as we can see here, that fits exactly within the envelope of the virtual tooth that we have created, allowing us to achieve a virtual abutment to a CAD-CAM abutment without even taking an impression. That is something that was in the realm of possibility today. So if we look at restoratively driven implant placement, and we want to be able to get the implants and coordinate that implant to implant distances, implant to tooth distances, and utilize the same abutment that we have chosen, and we want to link it then to the laboratory components, we have the tools to be able to do that today. So here you see different diameter implants, and we use the same virtual abutments that you can see here on the soft tissue model. So this type of technology allows us to have accuracy, consistency that we cannot achieve utilizing any other methods. And I think it's very, very exciting for us. So I will conclude with this one last case where we can see a hopeless dentition in the lower arch, and we are going to extract all of these teeth. But before we do that, we're going to evaluate all of the views that I've described before, the cross-sectional, the panoramic, and you can see that if this patient sneezed real hard, that these teeth would come flying across the room. There is no bone holding these teeth in. We're going to plan the placement of these implants. We're going to assess the implants in the cross-sectional views. Of course, the teeth are flared out of that normal envelope. We're going to see if we can design a fixed detachable restoration to deliver at the time of surgery. And by looking at the three-dimensional reconstruction views, we can be able to look at the bone, we can look at the virtual teeth, the existing teeth, and make them disappear virtually, so we can look at the bony topography with very good scrutiny, and then we can plan to place our implants in the proper position so that they will support the occlusion. And when we can do that, we can use the tools to create parallel placement, which I believe is a tremendous aid when we're going to be doing CAD-CAM type of reconstructions. We can also take a look at the path of the nerve and even examine areas where we might have an anterior loop of the inferior alveolar nerve. And so when we have that capability and we can use the virtual template, the virtual teeth, to create virtual process, we would then go into creating these virtual templates to be able to go in, have 5 implants that are parallel, understand where we might want to fixate these screws for the template itself. As you can see here, we've actually planned the fixation screws so that they don't interfere with vital anatomy or the implants that we're going to place. That is a wonderful addition to the planning tools, to be able to actually plan the fixation, not only for templates, but we can also do this with bone grafting simulation as well, which is not the topic of my discussion today. And so when we have the capability of using selective transparency and being able to combine all of these elements, it gives us a tremendous advantage when we're trying to complete these cases. And so we can then take the stereolithographic models, we can place implants into them, or create from a different process a model that we can then create our prosthesis from. We can remove the teeth, we can place the implants very parallelly, we can go in, take our bone and fill, because we're going to place these in a transitional position at the height of the lingual bone, leaving perhaps some of the area on the facial that we need some support, not for the implants, but we need support for the soft tissue. We'll use a rubber dam in this particular case, and then we can deliver for this patient a temporary fixed restoration that mimics the occlusion that he came in with. And we can examine that occlusion by taking a look at the occlusal view, showing the 5 implants as they are placed, and then we can superimpose the virtual plan that we have, and they're almost identical. And so this type of reconstruction allows us to be able to improve the condition of the keratinized tissue. We've widened it very nicely. You can see that all of these implants are parallel. They're nicely spaced, good anterior-posterior spread. And we have confirmed that the plan and then the actual placement are accurate. We're then going to be able to use conventional prosthodontic concepts to be able to create a CAD-CAM bar. But wouldn't it be nice if we could go directly from the CT to the bar? That's the next step. But right now, your laboratories will be very, very happy if the implants are perfectly parallel and we can have a seamless connection between the bar and the implant, having no abutments at all, so that we have less parts that can come loose, micro movements, etc. And so we can create a CAD-CAM fabricated bar. We can create this through the CAD-CAM process, and it's always nice to be able to go through the regular prosthodontic protocols to be able to check the bite, do our wax up, articulated models, everything that we normally would use to be able to complete our restoration. So we're not going to forego any of those concepts. Conventional prosthodontic protocols must be followed in order to achieve this type of success. And so the definitive prosthesis, we would know in advance, and we can deliver this at the time of surgery if we wanted to, with specialized abutments that some implant companies have, or we can do this after the healing process has been completed and then deliver the definitive prosthesis. So as you can see here, I happen to favor delivering the definitive prosthesis later rather than earlier. So to conclude, I'd like to be able to state that technology is really here today to help us. And if we ignore some of the technology, we're going to make mistakes. And in order to be able to appreciate the technology, we have to be able to use all of the views at our disposal to create the plan so that we can make the decision of whether to do immediate load, to do flapless surgery, the abutments that we're going to use, or to use CAD-CAM technology to assist us in the restorative phase. To me, this is the greatest communication tool that exists between the specialties, between the surgical specialist, the restorative dentist, the laboratory, the patient. It's also, I believe, one of the greatest marketing tools that we can ever employ in our practices. Technology is our friend. As I said before, I think we should embrace technology. It helps us to make educated decisions. It helps us to avoid mistakes. It helps us to increase accuracy. And I believe that we are just at the tip of the iceberg to being able to go from the scan to the abutment, to the crown, to the CAD-CAM mill bar. And I'd like to be able to address you to my website if you'd like to be able to look at some of the other articles that are in the literature to be able to learn more information about what I've discussed with you in this brief amount of time. And there is one particular one that just came out in the dental clinics of North America that actually talk about this exact topic. I really appreciate the opportunity to come to Chicago and to speak to all of you today at this wonderful meeting. Thank you so much for your kind attention.